I'm going to try and open up the coronal to mid-third, and what you'll notice here that I have adjusted the stopper on the glide path file up to where the flute stops, so that's 16 millimeters, and I am just sweeping the file in and out. Hi, welcome to this week's clinical case, and today's case is going to go straight back to basics, okay? So we are going to do a full procedure from start to finish on an upper left 7. Before we start though with the case, what always blows my mind is when I look at the metrics on the channel is that 56% of the people that watch these videos are still not subscribed. And what I just ask you to do, it's a really easy and free way of supporting the channel, is just to hit that subscribe button. And if you hit that subscribe button, I can promise you that it supports the channel, and I will continue to make these videos more informative, more detailed, and it just pushes me on, so thank you. So when we look at the case here, we can see that this is a case of an upper left 7, okay? Now, this patient was referred to me externally, and there was a suggestion that maybe the upper left 8 and the upper left 7 had a poor prognosis, and the external referrer had suggested to me that I investigate both these teeth. Now, the upper left 7, just by looking at the x-ray, not even looking at the patient, instantly I know that this tooth has got necrosis or irreversible pulpitis, and also there's a suggestion maybe there's sorts of inflammation at the end of the roots here. But if we look at the 8, it's a questionable prognosis, and it transpires that once I removed all the decay and I filled the tooth was found to be vital, and that's just a simple restoration, composite restoration. So we look at this upper left 7, and obviously my main concern here is restorability. So the radiolucency on the x-ray is quite significant, and in the first instance, before we book any appointments to complete the root canal, I want to check that the tooth is restorable. And in this case, what we did is we booked a half-an-hour appointment with this patient, we removed all the decay, and then we placed a proper filling material in this tooth. And this is useful for many reasons. Not booking a massive root canal appointment is that it's cost effective for you and the practice, so you're not booking 2 hours or an hour with a patient and then you find out in the first 10 minutes that it's not savable, because obviously then you've got an hour and 50 minutes left to do nothing, which is not great, again, like I say, for cost effectiveness. But also it gives the patient time to get to know you. And I know it sounds a bit strange, but in a way, as dentists, we kind of we do this all day, every day. So it's kind of like a bit of a busman's holiday, isn't it? It's kind of like it's all run of the mill. But for your average Joe on the street, coming for a root canal can be quite daunting and also quite worrying. So I think, especially if the patient's quite nervous, is you book them in for a nice, cheeky little half-an-hour appointment. And in that time, you can get them in, you can numb them up, you can just show them that, the treatment isn't as scary as they think it is. It's also a great way to dress the tooth, and if you've got time to sort of very slowly look for any canals. And basically, if you've removed all the decay, you've put a nice filling in there, you've kind of scouted the canals a little bit. When you come to do the root canal at a later date, you're just getting the patient in. It's all ready and waiting for you, and then what you can do is you can just then concentrate on the root canal. There's nothing worse than booking, a 2-hour appointment with a patient and then spending the first 30 to 45 minutes not doing the root canal and doing something else. So I'm always a huge proponent of booking a 30-minute appointment on occasion. Of course, there are those occasions where I will just go straight for the root canal. Sometimes patients, the tooth is okay and the patient, is nonplussed. Maybe they've had root canals in the past. But it's just, sometimes it's nice to split the appointment up just for the patient. And of course, the most important thing and the first thing you've got to do is place a rubber dam. In my book, if you can't put a rubber dam on a tooth, we're not doing root canal, and there is no ifs, no buts there. In any circumstance would I not do a root canal without a rubber dam. Okay, it's medical legally it makes sense, and also it makes sense in the sense that it's gonna isolate the tooth from the rest of the mouth. So the whole point of root canal is to disinfect the cavity. And once we've removed the temporary dressing, we can see now we've got the palatal, we've got the mesibuccal, we've got the distal buccal, and also we can just about see a very, very small orifice there. We can see the MB2, which is really, really encouraging. So we know we're onto a winner here. So we're going to irrigate the tooth. What I like to do is that I like to fill the cavity space full of irrigant, the bathtub technique. And this is obviously going to disinfect the cavity, and it's also going to lubricate your instruments. And the first canal I'm going to go down is the palatal canal. I always feel like if I get down the palatal canal, it's it's kind of a nice and easy bit of low-hanging fruit. And I'm going to use a size 10K file here, rightly or wrongly, to take the working length. And I'm going to just very, very gently watch wind this size 10K file down the palatal canal. I'm just going to move the rubber stopper out the way here. And then what I do like to do is I like to just ever so slightly push the file through the apex. I like to back the file back out and then push the file again up to the apex and then bring it back out. And I feel like this gives me the correct working length. And obviously we're going to adjust the rubber stopper to a reproducible point. In this case, I'm using the palatal cusp. Of course, using a cusp can be sometimes difficult because it's not like a flat plane. But in this case, we measure the size 10K file and we can see that the palatal canal is 22.5 millimeters. So our first protocol is I like to use a glide path file. I'm using a HyFlex 1503 here, and I'm going to measure this file up to the 0 reading, and I'm just going to obviously just give the canal a nice shape, and then we're going to use a size 25 HyFlex variable 0.5 millimeters away from the working length. So I am shaping this palatal canal to 22 millimeters, and I am getting a little bit of resistance from this. So what I don't want to do is I don't want to push it too far. I'm going to irrigate. Make sure you do lots and lots of irrigant. That's really, really important. And then I'm going to recapitulate with this size 10K file. So what I mean by recapitulation is I am pushing this K file back down the palatal canal to length just to make sure the canal is still open. And then we go back in with our master apical file, and we can see here now that it's shaping nicely to length. So that is it. That's the palatal done nice and easily. And again, lots and lots of irrigants. I like to place the irrigant in all 3 canals as I'm moving along, and then we're ready to do our next canal negotiation and working length. And in this case, I'm going to go down the DB canal. Again, I'm going to use a size 10 K file, and I'm just going to just ever slightly just do like a little bit of watch winding. And then when we place the apex locator onto this K file, it goes straight to 0. This slightly is the problem with using this bathtub technique, is sometimes you can feel like you can get to 0 and you're not really down the canal much. But in this case, what I'm doing is I'm just watch winding this K file until I just poke it out of the end of the apex, and I'm going to back it up, poke it through again, and then just back it up. And as I back it up and it reaches 0, in my book that is the 0 reading, or the anatomical apex within the tooth. Obviously we're going to move the rubber stopper. This time I'm going to use the distal buccal cusp, and then we can see now that the distal buccal 0 reading is 21 millimeters. And again, it's the same protocol. We're going to use a size 1503 HyFlex at the 0 reading at 21, and this glide path file has more resistance associated with it than the palatal because it's not as obviously wide. But I'm just using gentle sweeping motions here. Again, lots and lots of irrigant down all 3 canals, and then I'm ready to use my master apical file. Again, this is a size 25 variable HyFlex 0.5 millimeters away from the 0 reading. I'm going to shape this dB canal to 20.5, so that's minus 0.5 millimeters away from the working length. And you know, you've got to be really, really careful going from a 15 up to a 25. In this case, again, the cutting efficiency on these high flex files are really, really nice. I didn't take much to push it down, but again, I'm always going to recapitulate with a size 10K file if I'm getting a little bit stuck. We're just using tiny, tiny little watch winding motions. And once I've recapitulated with the canal, again, I'm just going to do one last sweep with the master apical file. And you know, we're blasting away at this. We're on our third canal. We're going to go down the mesiobuccal. It's a little bit tough down the mesiobuccal. I'm just using a few little watch winding, and then we're ready to do our shaping and negotiation on the mesiobuccal canal. The mesiobuccal canal is usually the one that's the tightest, of course, notwithstanding the mesiobuccal 2. And you know, when we place the apex locator on this file, again, we're just going to very, very gently push this, watch wind it to length. We're just going to push ever so slightly out the end, not too far because we don't want to damage the PDL any more than it already is. And then we're just going to back it up, out again, back it up, and then that's our 0 reading. And we're just going to adjust the stopper on the mesiobuccal cusp here. As we withdraw this file, again, it's found to be 21 millimeters. That's a 0 reading found on the apex locator. And again, ad nauseum, it's the same thing. We're going to use the glide path file to 21, the 0 reading, and then we're going to use our master apical file. And if you're not using glide path files, I would strongly suggest that you do use them. I think now the consensus is that using the glide path file over hand files is safer. Again, I've got no evidence to say that is correct, but you know, it's just lots and lots of talk with colleagues and just my own anecdotal evidence. So once we have obviously shaped, we're going to recapitulate. That's really important, especially in canals like the mesiobuccal where it's quite tightly sclerosed. And of course, don't forget to recapitulate down the mesiobuccal canal, especially if it is quite tightly sclerosed. And then we like to do a nice final sweep with the master apical file. So now we are ready for the MB2 negotiation, and you'll notice here that I'm using a size 8D finder, and you'll notice also when I try to negotiate down this canal, I'm getting a little bit stuck. And you'll also notice that where I'm getting stuck, it's up to the point where the flute stops, so that's about 16 millimeters that I have negotiated down this MB2 canal. So that's kind of a rough guide of how far I've got. And what I want to do is, because I'm not negotiating down this MB2 canal very well, I'm going to try and open up the coronal to mid-third. And what you'll notice here that I have adjusted the stopper on the glide path file up to where the flute stops. So that's 16 millimeters. And I am just sweeping the file in and out. My purpose here is not to negotiate past the 16 millimeters, but is to open up the coronal to mid-third. That's the most important thing. So I'm not pushing that glide path file any further. And again, I could use an orifice opener, but more cost effective here, I am just going to use the master apical file used for the 3 other canals. And we're going to irrigate, lots of irrigation down all of the canals. And when we look at the base of the cavity here, you can see the MB2 orifice is a little bit wider. So I am going to get my size 8D finder again down this MB2 canal, and you can see now that it's moving past the flutes, so we know we're getting past 16 millimeters. This is dropping down quite nicely, and you can see here the power of opening up the coronal to mid-third with other files. And when we place the apex locator on, straight away it screams that we're over, which is unusual because all the other canals are around 21 to 22. So I'm always worried about perforation when I place a apex locator straight onto a file. But in this case, what I think is giving me a poor reading is that for some reason the cavity is got too much irrigant in it. So what I'm going to do here is I'm just going to pull out some of the irrigant from the cavity, and you can see here now that the apex locator is giving a more accurate reading. Of course, I am using a size 8, so using a size 8 to get the working length is probably not the best diameter to use. But again, it's the same protocol as before. We're just going to push the file in and out until we go through the apex, out, through, and then as we back it up and it reaches 0, that's our 0 reading. And we're going to adjust the stopper, and in this case I'm going to use the dB cusp. Sometimes it can be quite difficult, especially if the patient's closed up, to try and move this stopper around. And as we withdraw this 8D finder, we can see that the working length is 19.5. And you've got to be a little bit more careful shaping an MB2 because what we don't know at the moment is if the MB1 and the MB2 join, of course. So if you're using rotary files and these are trying to go past a join, there's a strong risk of ledge or even fracture. So I am just being really, really gingerly here with the glide path file. And luckily in this case, the glide path file is just reaching to the 0 reading quite nicely. If I was getting any resistance, then obviously that's a bit of a red flag. You need to have a little think about what you're doing. And then obviously we're going to do some final shaping with a size 25 high flex. Again, some people may argue that going from a 15 to a 25, especially in MB2, is probably a little bit too much of a jump. But as long as it's pushing to length quite nicely and there's no resistance, then, why not? But always be mindful of pushing it too far. Always be mindful of not pushing these larger diameters too far and too hard. And then when we come to irrigate the canal here, we can see that when I aspirate and irrigate the MB2 canal, the MB1 canal does not irrigate and aspirate the same. So again, that is a strong indication that the two canals aren't joined and they've got their own separate canals and their own separate portals of exit. So once we've shaped all 4 canals, we're ready to do our comfort radiograph. Again, I like to use this kind of GP disinfecting wheel from Style Italiano. And when I fit the cones, I always like to measure the GP cones in this great little measuring block. I obviously push it down the little hole here, and then I always measure it on the side. I then crimp the point where the GP cone is at the correct length, and I push the GP cone to length, and I feel for that tug back, so we know that the tip of the GP point is fitting snugly at the apex. And using this disinfecting ring is really, really nice because it sort of creates an area of where the nurse knows where to put all her bits, and it's like a focus point. And it's sometimes if you work with lots and lots of nurses, they sometimes like to put things in places where they feel like they should go, especially if you don't work with someone a lot. And you can just kind of say to them that this is kind of the area where I like things, and it just makes things nice and efficient. You'll also notice here that I like to chop the ends off the GP cones. I like to chop the ends off the GP cones for 2 reasons. The one is that when I come to do my comfort radiograph and I sort of folded the rubber dam out the way, sometimes the excess GP that's sticking out can be sort of pulled away by the rubber dam. But also when I come to obturate the tooth, it serves as a kind of a marker to how far the GP cone should be pushed down. So it's horses for courses, really. A friend of mine who works just up the road, she doesn't like to chop hers off, and it's just personal preference. You do what you think's best for you. And the final one's always difficult. For some reason, I always put the GP cone down the palatal first, and I think that trying to place the the cone in the MB2 here is difficult because one, the MB2 is quite small anyway, but also doing it on the last GP cone can be frustrating because there's other GP cones in there. So that's something to be mindful of. You know, sometimes if you're pushing the GP cone down, you can sort of blunt the end. And then when we look at the cone fit radiograph, it looks fantastic. We've got all of the GP cones. They're all within the working length. You know, they're not sticking out the end. They're sort of about 1 to 2 millimeters away from the radiographic apex. So in my book, I feel like that is appropriate. And then the second stage is our final irrigation protocol. Again, I like to use this disinfecting cone here. So I'm just going to place the hypochlorite in the correct sort of wells. And then I like to use this EDTA in a different well. Basically, what I do is I take out the GP cones. And then as I pull the GP cones out, I just make a mental note of which canal that's come out of. And as I place this cone, I notice that I've forgotten to fill up the MB2 well here. And yeah, it's just you'll notice on these little rings that around the side it has the indication of what canal's what. And you know, before I used to kind of put them in order, and sometimes I used to get a bit mixed up. So this is like an unequivocal way of knowing which cone goes in each canal. So now that these GP cones are disinfecting in their hypochlorite, I'm gonna just irrigate the canals with sodium hypochlorite. I use copious amounts of 2%. Some people like to use 5%. It's activated with ultrasonic activator. I then suck up the EDTA with the same syringe, and I'm going to use the same irrigation tip to then irrigate with EDTA. And then what I do now is I like to disinfect the size 10K file. Much discussion online with other people. I've started to disinfect my size 10K file ready for the obturation later, and I'll show you why I disinfect this in a moment. And then, you know, I'm going to use the EDTA as a wash after the sodium hypochlorite. I'm going to, you know, copiously irrigate and activate the EDTA. This removes the smear layer from when you were shaping the canal space. It opens up all the tubules because obviously the tubules are full of bacteria. And then I use the same hypochlorite that I used to disinfect the GP cones to do my final irrigation. And then I'm going to irrigate with my sodium hypochlorite until once I've irrigated and activated, the irrigant stays clear, so we know that we've got all of that nastiness out. And then we're ready to do our drying. Again, I'm going to use this kind of dry area here on this little ring, and I'm just going to pick the cones up, and I'm going to fit these paper cones to length, and I'm just going to inspect the end just to see if it's dry or not, and I'm going to just use this until the canals are completely dry. And then we're ready to obturate. I am going to, first of all, pick up the GP cone with my tweezers, and I'm just going to wick out the water. That's important, and I'm going to place that to one side, and then I'm going to use my Bioceramic with a visco tip, and I'm going to just add this under magnification, of course, directly into the canal in the coronal third, and I'm going to use my disinfected size 10K file just to introduce the Bioceramic to length. Okay, so I'm not, you know, giving it a good old push up and down. I'm just gently pushing this file to length, and then we're going to pick up the cone, and then we're going to place this cone very, very, very gently to length. Okay, so I'm going to push this cone really, really, really gently to the end. I don't want to ram it down. I don't want to have too much of an extrusion on this tooth. And then I'm going to use a heated plugger just to remove the excess GP. The heated plugger kind of sort of tidies up the end of the GP here, and then I'm going to use a Mach 2 plugger just to push the GP cone down to length. And you want to obviously push this quite firmly because you want all of the sealer to sort of reach all of the lateral anatomy and all the little nooks and crannies within the canal space. And again, it might feel like it's all repetitive, but we're using very careful and considered techniques for all of these GP cones. Again, we're just going to wick it out like we are here, get rid of the moisture. You don't have to touch the GP cone actually onto the paper towel itself, because obviously there's risks of reinfecting the GP cone. But what you do is you get the tweezers and then you touch that onto the paper towel, and then it kind of wicks out the water, so you're ready to place the cone to length, so the cone isn't full of hypochlorite. And then we look at the radiograph, and you know, it looks super nice. I suppose if I was being really critical, you know, possibly on the distal canal there is excess sealer. But we are using a bioceramic, so it's a very biocompatible material. And you know, from experience, when we do the post-op radiographs in a year's time, usually this sealer has disappeared. And you know, I was speaking to a friend about extrusion. And you know, they've got an opinion as if, you know, if you haven't extruded a little bit of the sealer, you could argue that you know, you're not patent and you haven't completely filled the canal space. I'm not too sure if I completely agree with that. You know, I really would like to confine the sealer to the canal space, but you know, doing these types of techniques is really technique sensitive, and you know, you've got to sort of just be kind to yourself. Looking at x-rays, you're always your worst critic, and I have got better at that over the years. Is if it doesn't look absolutely perfect, Instagram perfect on the x-ray, it's really not the end of the world, and it's really about, not really about the x-ray, it's about how you have conducted yourself throughout the appointment. You know, have you conformed to the correct disinfection protocols? Because it's not you know, it's not so much the obturation which is the most important thing, but really it is the disinfection protocol. So have you used rubber dam? Have you used you know, copious amounts of irrigants? Have you got that irrigant all the way down the canal space? Have you activated that irrigant? So overall, you know, again, another case and another week, and I'm super happy with this. And listen, if you enjoy the channel, like I say, the best and freest way to support the channel is hit that subscribe button. If you love the channel, there's a membership program. The membership program is a small monthly fee. It supports the channel, of course, but also you get early access to content. I'm usually working about 2 weeks ahead, so you'll have access to these videos 2 weeks in advance. And overall, I'd like to say thank you for supporting the channel. If you have any comments, criticisms, please place it in the comment section below, and I will see you next week in the next video. Bye bye.